Welcome to the FSBPT webinar. This could never happen to me, protecting yourself and preventing sexual misconduct. My name is Stephen Curley, and on behalf of the FSBPT and the Board of Directors, welcome. Today's webinar is student-focused. As future healthcare professionals, it's a matter of when, not if, you will experience difficult or inappropriate situations. It's essential to understand the importance of maintaining ethical boundaries and preventing sexual misconduct in physical therapy. We hope today you will be able to learn about maintaining professional boundaries, understanding the consequences of misconduct, and discovering how you can contribute to a safer, more ethical healthcare environment. Your presenters today are Mira Mariano, a PT, professor at Old Dominion University, and Vice President of the Virginia Board of Physical Therapy. Sherry Peru, PT, clinical advisor and investigator for the Oregon Board of Physical Therapy, and Samantha Munn Johnson, PT, professor, the College of St. Scholastica, and Vice President of the Minnesota Board of Physical Therapy. A few housekeeping measures before we begin. This session is being recorded. If you have a camera, please turn it on. If you have a microphone, please mute it. We will be using Slido today, so please have your devices ready and be prepared to log in when you see the QR code. And finally, if you have any questions, please place them in the chat and we will answer them at the end of the presentation. Without further ado, I turn it over to you, Mira.
Thank you so much, Stephen. Well, welcome everybody to FSBPT's first student webinar. We are really, really thrilled that you took the time to join us for the next hour. We know that you guys are working very hard in school and will soon be taking the NPTE. And so our objective tonight is really to share information about a topic that may put your future license at risk. So just a few learning objectives. The first thing I'd just like to say is I just want to put out there a disclosure for a trigger warning, because this presentation contains topics of a sexual nature regarding misconduct and harassment. So we understand that it might be triggering for some. And so we know that we just wanted to give a little warning before we go ahead and talk about this subject. But we're covering a lot of different topics tonight. We're going to talk about the patient-provider relationship and also about that power dynamic that exists in that patient-provider relationship. We're going to spend a fair amount of time talking about communication and informed consent, and then go through why physical therapy specifically, why our profession perhaps puts us at a higher risk than some of the other healthcare professions for these boundary violations. And of course, we want to provide you with resources that are available to help you to find more information about this topic. And then we are so fortunate to have Sherry Peru, who is an investigator for the Oregon board, and she's really going to spend some time talking about cases and what happens with some of these complaints and cases that come to different boards and what are the ramifications for licensees. But it's clear that we want to address these things early in your education and talk about these concepts early in your training and in your career, so that some of these topic areas will always be in the front of your mind when you're learning new skills and going out on your clinical experiences. Next, Jeff. So let's talk about what is the prevalence of sexual misconduct by licensed professionals. And so really the bottom line is that it's minimally studied, but this problem is not minimal in the healthcare professions. And so on recent studies, especially one that was published by the Healthcare Regulatory Institute, patients were surveyed about receiving care from different healthcare professionals, and it was found that 15% of misconduct was of a sexual nature. And then when we look at one of our most popular physical therapy liability insurance companies, HPSO, when they looked at data from 2020, 18% of the cases that were defended by our liability insurance company actually were of a sexual nature. So that's almost 20%. But the problem is that we know that even though sexual misconduct is experienced by many of the patients and the public in healthcare, it's severely underreported. So from a 2019 study looking at the medical boards, only 5 to 10% of those cases were of a sexual nature. So we believe that underreporting is a problem, and that is understandable. If somebody has experienced something like that while receiving care from one of their healthcare providers, do they want to report it? Do they know how to report it? Do they even know how to find a complaint form on a board website? So these are all issues that contribute to the underreporting. And then last but not least, in a 2017 study in physical therapy that asked PT, PTA students, and clinicians if they've ever experienced inappropriate sexual behaviors, 84% had reported that they had experienced those behaviors over the course of their career, and 47%, almost half of the people surveyed, said that they experienced inappropriate sexual behaviors in the past 12 months. So part of what we would like to accomplish in this webinar is to just make you more aware that these things happen, and how do you respond to these inappropriate sexual behaviors. Next. So you can get out your electronic devices or your phones and go ahead and scan this QR code. And if for some reason your device does not pick up that QR code, you can just go to slido.com and then plug in that number, the 1141645, and that will get you to the site. So I'll give you guys a couple minutes to sort of get all logged in with our Slido. And if for some reason you lose that particular page on your device, every question that we bring up will also have that number on it, so you can log in at any time if for some reason you get kicked off. So the first question is, tell us a little bit about yourself. Who is joining us tonight? I love watching those bar numbers kind of roll up as you guys are responding. So it looks like we have about 260 some people joining us. So I'll give you guys a couple more seconds to respond. So we have a lot of DPT students. We have PTA students. I see a couple of faculty. There's other. So hopefully maybe clinicians that are joining us. So we really tried hard to get the word out about this webinar. So this is pretty amazing that you guys are taking the time out, because on the East Coast it's 7 o'clock at night, like dinner time. All right, so tell us a little bit about what region of the country you're in. The Midwest is killing it right now. So we actually have participants from pretty much every region of the country. That's amazing. All right, this Midwest is still killing it at more than 50%. So go Midwest. All right. Oh, somebody in the chat put far Northwest Alaska. Hey, Rebecca. So we're going to get right into the first question. It's, when is it okay to date your patient? So far the vast majority is it's never okay. But we do have some that say it's okay after they've been discharged. And we're going to talk about this during our presentation because depending on the jurisdiction, there may or may not be rules and regs regarding that. So then this next question is a little bit different. Is it okay to discharge a patient or maybe just transfer them to another therapist caseload so that you can pursue a dating relationship? We got the it depends on there. My students love it depends. So again, the vast majority responded in the negative, that it's not okay. So hopefully by the time we get through this presentation, you'll have a definitive opinion about these questions.
I don't think providers realize how much influence they have with their patients. I think some of us think, oh, we're just physical therapists, but that actually comes with a lot of weight.
Licensees, students, you never think something is going to happen to you.
In physical therapy, we develop a very direct relationship with our patients. Some healthcare professionals, it's at an arm's length. With us, it's one-on-one most of the time. And in that, there's an inherent relationship that develops.
The goal is to educate students that there's more to physical therapy with this whole patient-provider relationship.
I think physical therapists need to appreciate that how we're trusted comes with a really high level of responsibility. Sexual misconduct in the workplace is anyone who's doing something other than what they're supposed to be doing, touching a person in the wrong way, speaking to a person in the wrong way, introducing sexual language, sexual innuendos, sexual jokes. It could be your patient, it could be your patient's family member. There's no room for that.
Even though we're a very touchy manual therapy profession, sometimes they never think that something that they're doing could be misconstrued in a negative way.
You are responsible. It doesn't get shifted onto the patient. You're responsible for putting the brakes on when it comes to anything that could be construed as sexual misconduct in the workplace.
I think it's always important to recognize that there is a boundary between the provider and the patient, that your role as a physical therapist or a physical therapist assistant is to help the patient achieve their goals related to the problem that they're coming in for. It's not being integrated into their entire lives. It's not creating a lifelong relationship. It's helping them out in like a snapshot of time.
Students need to think about it right off the bat and recognizing that the bar is now even higher when it comes to a patient.
Because of the training of physical therapists, it's very task-oriented. Without proper communication, proper asking and getting consent where you're putting your hands on patients, it can get pretty sticky if any of those steps along the way are missed.
By the time they're ready to go out into practice, they may not be perceptive enough until they're confronted with the issue. Then there it is right in front of their face. They realize, oh, this is one of those experiences that they told me I might have. We try as much as possible to get them to think critically. What is the best thing for me to do at this moment, and what is in the best interest of the patients to protect them?
I think it's always in the forefront of the physical therapist to remember what they're doing, why they're doing it, how they're doing it, if it's okay if they do it with these particular techniques so that there's no misunderstanding.
You have to kind of be really aware all the time. I think it could happen to any of us.
I think we always all have that ability to be someone who violates those professional boundaries based on what's going on in our lives.
Preventing issues, it puts you in a better spot. I'm going to put in place making sure that I gain informed consent, that I explain what I'm doing to my patients, that I ask for a third party to be available if I feel uncomfortable or if my patient is seeming uncomfortable.
Communication is probably one of the biggest things that we see in many of our cases. And if the provider had just communicated what they were going to do, why they were going to do it, all those things, then there wouldn't be a complaint filed against them.
By starting those habits early and doing them ahead of time, you're not having to justify the choices that you made, not having thought about them.
With students, I think a little bit of it is exposure. And knowing that it's not just about a technique that they passed a written exam, that there's more to physical therapy with this whole patient-provider relationship. It is a professional-patient relationship, not a social friend relationship.
We all have our different boundaries in our personal life, but in our professional life, there is only one boundary. Your patient is your patient. You are a PT, and that there's the line that's very clearly drawn, and state laws address that.
With regards to students, we teach them to embrace the responsibility of being a physical therapist, but also keeping in the back of their minds, like how you deliver that care makes as much of a difference as the actual care that they're giving as well. Always remember the role that you play in your patient's health care, and always remember that those are the things that will keep you practicing for a long time into the future.
There are so many things I love about that video. I've seen it probably 5 or 6 times, and every time I watch it, I'm like, yes, that, or this. You know, a couple of things I really heard. Our job is to protect the patient. Our job is to be professional. Our job is to work with them in a snapshot of time and have these professional boundaries. So let's talk about boundaries just a little bit. What are boundaries? In the simplest sense, they're borders, sometimes rigid, sometimes flexible. They're the lines that separates what's the professional relationship and what's the personal relationship. There's all different kinds of boundaries, physical boundaries, like personal space. Is somebody too close to me? Is somebody touching me when I don't want them touching me without asking if it's okay? There's emotional boundaries, like what are we talking about and what kind of conversations are we having? You know, should we have a conversation about things that really have nothing to do with what the patient's coming to therapy for? Is it something too personal? If they're oversharing, what do we do about it? Should we overshare back? No, but it's really hard. Those emotional boundaries are really hard, especially when a patient starts sharing with us, you know, how do we react to that? You really don't want to get too involved in your patient's life, right? And their personal things that they want to share with you. Also time, you know, there's time boundaries. How much time do you spend with the patient? There's this nice happy medium of you spend the appropriate amount of time, but if it's too short, patients get upset. If it's too long, does someone start to feel like, oh, I must be special, they're letting me stay here for 2 hours, or I came early in the morning before everybody else got here, or they're letting me come in on the weekends and do extra therapy, or come in at a time where other people aren't allowed to come. You know, does that wind up being an issue? And then, you know, also that boundary of privacy and confidentiality. Patients trust that their information is confidential, that they share with us, or that we see in their medical record, and that we're not going to share that with anybody else, and that we're also not going to access it when we shouldn't. You know, someone's been discharged, we don't go into their file a year later, say, oh, I wonder what so-and-so is up to, or I feel I was attracted to this patient I saw a year ago, I'm going to go in and look up their phone number and give them a call. You don't have the right to do that. You know, everybody's entitled to that confidentiality as well. So, you know, really, it reduced the boundaries, reduce the risk of harm or exploitation in both directions, and also uphold the integrity of our profession. Next slide, please. So some of the boundary issues in physical therapy, they talked about this a little bit in the video, and I feel pretty strongly about this, that, you know, being a physical therapist myself, every one of us has this, what they call a violation potential, which you could be the person at any moment that could violate professional boundaries, because it's dynamic and it changes over time. If you have the one physical therapist and the one patient on the wrong day and the wrong time, where you had a really bad day and they had a really bad day, and you guys start having this conversation about it, and then next thing you know, you're texting, emailing, following each other on social media, go out on a date, and next thing you know, it just gets blown out of proportion. I recently interviewed somebody that said to me, you came to talk to me in PT school, and I was sitting there and listening to you, kind of thinking, this is kind of silly. This is never going to be me. And here I am sitting in a room with you. And I never thought this would be me that this happened to. But the circumstances of her life mixed in with the circumstances of her job and her patient's life, here she was. So it can be a slippery slope that can happen to anyone. Perception is really important. Like if it looks bad, it is bad. If even if your intention is totally a positive one, or you're really just trying to help the patient, if someone else perceives it in a negative way, sometimes I'll go back and I'll look at records, or I'll go back and look through text messages or emails, and I'll read something back to somebody and I'll say, look what you said to this patient. And the person's like, oh, I can't believe it. That looks so bad now that I go back and look at it. But in the moment, you didn't even think anything of it. I'm kind of really big on not including emojis when you're communicating with your patient. Emojis can cause all kinds of different things. It's like, whoa, my therapist emailed me and they put a smiley face. What does that mean? Or there's a little wink. Maybe you didn't even mean the wink. You meant the smiley face, but you put the wrong one. So I'm a big proponent of don't put emojis in things. But, and protecting yourself is a priority. I would say a good portion of the cases that I investigate come from a patient being the person who is, well, initiating the complaint, but also initiating the inappropriate conduct, and how a physical therapist or physical therapist assistant handles that inappropriate conduct is what then spirals into the complaint being filed. Next slide, please. So here's a Slido question for you all. How many of you have had patient ask to follow you on social media, or ask for your phone number or email address? So more than half of you so far, yes. And I should say, it doesn't matter if the patient's a current patient, been discharged, just somebody who has been in your care. So we've got mostly no, which I'm actually happy to see that answer. Yes, and then some depends. So I'm kind of surprised by that answer, because I feel like that happens quite often. So I'm glad to see that. So let's talk about the therapeutic relationship. So, the therapeutic relationship is based on trust, respect, sensitivity, duty, and then let's not forget about that power. Even if you feel like the patient may have power, you have a patient who is very successful, or somebody who is older than you, or at a different, level of education, you have that power because they are coming to see you, and they are there for you to get them better. So that power imbalance is always there, regardless of whether we think it is or not. It's always important also to always get informed consent for everything that you're doing, not just sign a paper at the beginning of the visit and not say, oh yeah, we got consent for that treatment. They know what we're doing, but to always consistently reevaluate those boundaries and reevaluate the consent for any procedure, especially if it's something that involves you touching a patient in a sensitive area. And the next slide, please. So here's a scenario. We spent a lot of time talking about these cases and looked at real cases that we've seen across our committee. Our committee has 7 people. And a lot of us have seen many of the same issues. So patient says to the therapist, I have an extra ticket to the basketball game. Would you like to join me? And then the therapist answers, well, kind of feels awkward, doesn't know what to say, says, okay, I'd love to, but I'm busy that night. So then the patient answers, and the patient says, okay, maybe we can do it another time. And then the PT says, yeah, okay, hopefully it works out. So maybe the PT means, no, I really don't want to do that, but I'm just going to say this because it feels awkward. So that's what I think some of the issues are. This is just going to be a type in everywhere. I love somebody says everything. What are some issues with this conversation? Everything. It's leading, cringe. Oh, I love that. Not shutting it down immediately, giving false hope, misleading. I love that. Avoiding conflict. Absolutely. It's like, you do not want to deal with, this is not appropriate. So let me just say, okay, maybe some other time. Didn't shut it down. I love how misleading is not moving out of the middle of this box. So that is exactly right, because what happened in this case actually is the patient, it's kind of like a dating app, right? You meet someone, you're like, oh, let's go out Friday night. Sorry, I can't Friday night. That person thinks, oh, so I'll ask him for the next Friday night. Or maybe they really are busy Friday night. Instead of the therapist saying, I am your therapist and this is a professional relationship, and no, I'm not going to go with you. They just said, oh, maybe some other time. Well, this patient actually really thought that the therapist was leading them on, that they were in a personal relationship. They actually really were attracted to each other. The therapist was just busy. So all of these answers are really, really good. It's awkward, avoiding conflict. It's definitely better. I've seen so many cases where people, in the course of trying to avoid conflict and just saying things like, oh, sure, some other time, oh, that would have been nice, I would love to do it, instead of just nipping it in the bud, in trying to avoid that conflict, wind up making it a lot worse. And then they wind up in front of me having a complaint filed against them. So I really like all of these answers.
All right,
So
so
Oh, go ahead.
I'm just going to go a little deeper into the power dynamics component that Sherry has kind of already started alluding to. I think one thing that's important to think about is just that with any relationship that you're in, any interaction really that you have with another person, there is an underlying construct of power in that dynamic of how you relate to each other, the reasons you relate to each other in the ways that you do. As Sherry alluded to earlier, within the patient-provider relationship, there is always an inherent imbalance in the power between the patient and the provider. Initially, really, the patient is seeking service from you. And they're seeking service because you have expertise, you have training, and you have knowledge that they need, right? They need to be able to get better. So it's putting your patient in a vulnerable position just because of, they need something from you and you have that to offer. Additionally, they may feel vulnerable because of, a new condition, something that they don't understand, they're not familiar with. It may also be, they're injured and they're feeling vulnerable. I didn't think I could get injured. I didn't think it would be me. And it may even be the physical position of the patient, depending on the intervention or the examination that you're doing with them, may actually have them feeling quite vulnerable. One thing that I think is also important to consider in this idea of the power balance between the patient and the provider, or really between any two individuals, is that there are also kind of those personal factors that can kind of make you feel like one up, one down, where do things balance out? So some of those factors might be things like the gender of the two individuals in the interaction, the age of the two individuals in the interaction. Sherry alluded to earlier, perhaps it's access to resources, somebody who's, very successful, has a lot of knowledge, high levels of education, those kinds of things. So as for example, if you are a young female therapist with not very much experience, and you're treating an older male patient who has, high levels of success, high levels of education, that can feel like there's some imbalance in terms of kind of those social constructs, where it may actually feel like your patient has that one up on you. However, there is still that patient-provider imbalance that exists. And so it's kind of that, like, how do you, kind of feel out both of those things at the same time and move forward in the best way for your patients. Next slide, Jeff.
All right, so we have another Slido here. How many of you have had a patient or a coworker make a comment to you in the work setting that has made you feel uncomfortable? So as the numbers kind of roll in here, I would say we're staying pretty steady at kind of an 80-20 split, which I think is really interesting. Mira alluded earlier to a relatively recent study in which 84% of PTs, PTAs, and student clinicians reported having some kind of inappropriate behavior directed towards them. And that study actually was initially done 10 years before that. And then I believe 10 years before that as well. And those numbers have stayed really consistent. And you all are showing actually a really consistent number here as well, which is really, it's pretty telling, honestly. Next slide. So for those of you who said that someone had made you feel uncomfortable, what was your response in the moment or in follow-up? Laughing it off, ignoring it, walking away, complete silence, brush it off. I'm feeling a theme here. Telling my CI. So we're definitely seeing a number of kind of that like, ooh, I don't really know what to do. I'm not quite sure how to deal with this. And so I'm going to avoid it. That same study looked at, kind of what were the responses. And the majority of providers, and particularly the majority of students, tended to kind of brush it off, ignore it, avoid dealing with the situation, and kind of hope it wouldn't happen again. And again, I would say that feels pretty consistent with what we're hearing from all of you. Next slide.
Every decision that a physical therapist or a PTA makes, they need to understand that there's a power imbalance there because that person's vulnerable. They're looking up to that professional for help.
We try to explain to students in educational curriculum to always think about that power differential of the patient-provider relationship and not putting them at risk for blurring that boundary or crossing that boundary.
The delivery of healthcare today isn't done with a doctor the way it was 30, 40 years ago. In fact, today you might see a doctor for 10 minutes total. What you will see is maybe a nurse practitioner or a registered nurse or a physical therapist for that matter, for hours on end.
People go to physical therapy because often they're in pain or they're not able to do the things in life that they want to do. They're already vulnerable. And if they're going to go to see a physical therapist, the physical therapist should know this about their patient and know that they have to be very conscientious about those boundaries.
When we go into that situation, there is inherently a power imbalance or a dynamic that you should be aware of, both the PT and the patient. You are not walking into this scenario with a patient on the same playing field.
Think about what you know about your patient when they come in to get therapy. You've looked through their chart. You know how old they are. You know what medications they take. You know their social history. You know their medical history. You know all these things about them. They don't know any of that about you.
You have this education that you understand how this medical history or this past illness or this past surgery relates to their current issues. Your name tag, the way you dress, what you're wearing, scrubs, professional attire, all these things play into it. And then when you start talking about, we're going to use this to treat you, or we're going to use a traction board, whatever it is, they don't understand what they do or how they work. So all these things build up into more and more of an imbalance between you and the patient.
I think it's really easy to just assume people know more than they do.
When patients come in, they don't always know how this relationship is going to play out. And they also have anxiety about whatever appointment is coming up.
That patient might have a history of some kind of victimization in the past.
Patients may be more vulnerable if they've experienced trauma before. They may be more vulnerable if they have feelings of insecurity or if they're not comfortable confronting issues. If they have mental health issues, they're more vulnerable. And so you don't know who's coming in that door.
The responsibility falls on the physical therapist.
Sexual misconduct and sexual boundaries is a little bit murkier water, and sometimes you actually have two victims in the matter. So you have a sexual misconduct situation happen between a licensee and a patient, and it may appear at first glance to be consensual. You don't realize that that power dynamic essentially nullifies that consent. When that happens, it may be that the victim in the matter doesn't even realize they're the victim yet. That's inappropriate. There's a power dynamic there that needs to be accounted for.
The physical therapist really has to understand that they're in a role where that patient is looking towards them for the best healthcare advice or the best treatment. That involves explaining to the patient what that visit is going to entail and explaining the details of everything that's going to transpire during the visit. If there's good communication, it relaxes the patient. They know exactly what's going to happen.
I think it's very easy for therapists to forget that that power dynamic exists and that we are always not at the same level of the patient.
So again, I think that video really nicely kind of outlines some of the potential risks associated with that power imbalance and just the perceptions that patients and or providers may have about power. We're gonna, the video, and I feel like, kind of all of the content up to this point has really focused a little bit more on, kind of just generally between a professional and a patient, what are, why are boundaries important? What are the risks? Understanding that power dynamic. We also wanted to touch on PT specifically, like what are the risks and why are we maybe at a little bit of an increased risk compared to some of the other professions that are out there. And I think we're all pretty aware of the fact that our profession is really a high touch profession, right? We are, Jeff, can you go back 2 slides? Yeah, there you go, right there. It's a high touch profession. So there's literally a lot of physical touch involved in the interventions and the examinations that we perform. Even something as little as, providing a gate cue may involve some kind of tactile cueing. And that can be misinterpreted or it can be utilized without really gaining that consent or explaining why that might be necessary. Additionally, in kind of a high touch kind of sentiment, we have longer treatment times with our patients and not just individual sessions, but also longer episodes of care. Interestingly, a relatively recent study discussed that of the healthcare disciplines that are out there, that the patient-provider relationship in PT has actually been identified as one of the most intense among the healthcare disciplines. And it's really because of those reasons, right? Our patients are vulnerable. We're spending a lot of time with them. We are spending time with them often in private treatment rooms. They may or may not be in some level of disrobe. Our patients feel vulnerable and they are in a vulnerable position. Additionally, and I think this kind of aligns with what we saw from all of you, this concept of duty to report. We all know it's our job to make sure that we're protecting our patients and that we're protecting our profession. And the physical therapists I think similar to what we saw in that last response from all of you, there's kind of that like, ooh, I don't really want to confront this situation. I don't want to harm the therapeutic relationship. I don't want to harm maybe the way that my colleague is interacting with their peers as well. And the study from Rausch and colleagues in 2015 indicated that researchers asked study participants how they would respond to an alleged sexual assault of a patient by a colleague. And the responses that participants selected generally distanced themselves from the situation versus either making a complaint to the board, even encouraging the patient to talk with the therapist, talk with the supervisor, or make their own complaint. So basically anything that kind of distanced themselves away from it, avoided the situation, was kind of the majority response. So some specifics about physical therapy in particular. Next slide, please. Additionally, we need to consider some of the risks of yourself as the provider and or the student clinician. So what's your personal context? Where are you at in your life? What stressors are occurring for you? Anything that might let your guard down. Maybe you're going through a really difficult time, with a family member. Maybe you've just had a recent injury and you're really identifying with that patient and what they're going through. And you start, kind of talking with each other and over-identifying with them. So just recognizing that in those moments where your guard is down, you may make decisions that you wouldn't make in another context or another time frame. Additionally, in that same article that we were talking about previously, some of the risk factors that were identified for the provider for experiencing some of those inappropriate behaviors from patients, the first and most important was experience level. So the more inexperienced a clinician was, the higher the likelihood that they would experience some kind of inappropriate advance from a patient. And it was not age, it was the experience level, which means a student is more likely to experience this than a practicing clinician. And an early professional is more likely to experience this than somebody who's later in their career, likely because, you haven't had the experience of noticing it and proactively kind of redirecting. Another important piece that was highlighted as a risk factor was practice specialty. So there are certain areas of practice in which perhaps you're working with patients with like a neurological diagnosis, cognitive impairments, and or just decreased inhibition, increase the likelihood that this is something that you may encounter more frequently in practice. Next slide. So as far as patient related factors, I feel like I've touched on most of these. So individuals who have some kind of cognitive impairment or inhibition, from as far as executive functioning goes, are more likely to make an inappropriate behavior or misinterpret the touch or the interactions with their therapist. Next slide. All right, so we have another scenario here. And again, this is based on a real scenario that I think this one was one of Sherry's. So the PT texts the patient, wishing you good luck with your surgery. This is somebody who they had been seeing previously, who's been discharged. Patient's thinking, hang on, where did the PT get my cell number? And decides to text back, thinking, maybe they think I'm kind of special. They figured out how to contact me, right? So can I still be your patient if I think you're hot? PT now feels a little bit flustered. That's flattering, thanks. Maybe I could stop by later, see how you're doing after your surgery. And then patient, again, is feeling like, oh, this person really cares about me. They're interested in me. Sure, that'd be nice. I'd love to see you. So same kind of question. What are some of the issues that you see with this particular text conversation? Everything. It's inappropriate. We've gone into the patient's chart, we've found their information. That's the first spot where you're crossing a boundary, right? Making a decision that really kind of invades somebody's privacy in that way. Another question, do you text all of your patients? If you're texting one individual patient, that probably is also crossing that boundary. Red flags.
I'm learning new words. I'm liking this. I mean, I know sus and bruh, but thirsty, I like that one.
All right. Go ahead and go to the next slide, Jeff. All right, another scenario here. This is one that we may see a bit more often in like a rural setting. So PT is working in a small community and working with a patient, and over time becomes friends with the patient. Their conversations progress to texting, kind of things that are unrelated to their PT sessions. Patients discharged from PT, and the two individuals, kind of run into each other, chance encounter at a bar, ultimately resulted in a consensual sexual relationship together. Later, the patient is now experiencing some ankle pain, and so the PT suggests that the patient return to the clinic for treatment. So first question, is it okay for the PT and the patient to be in a consensual sexual relationship following discharge? Yes, no, or it depends. Man, it depends. It's trying to make a big leap here. So we're seeing about half of you, a little bit over half, saying, no, this isn't something that's appropriate. About a third saying, it depends, and about 10% saying yes. And the answer is really all of you are probably kind of correct. So depending on the jurisdiction in which the PT and the patient are, or in which the PT is practicing, it may legally be allowed because the patient has been discharged. I think part of what our aim today is to kind of convince you that even if it's legally allowed, doesn't necessarily mean that it's a good idea. And so, we'll kind of continue to navigate this as we go forward. Next slide, Jeff. So same scenario, same PT and patient. Is it okay for this PT to treat the patient when they return to the clinic? Looks like we're getting a hard no on that. Good answer. The most appropriate thing would definitely be to, to transfer care to another PT to ensure that that professional boundary isn't crossed further or isn't an issue in that case.
One of the things that strikes me about that case is you started with this is in a small town. What if there is no other PT? What if you are the PT in that small town? Then what happens? Where does that patient go for care? Which is probably the reason why that relationship should not have started in the first place, because then that limits your patient's ability to be able to get care if there's no one else to get it from. The other thing that I just want to touch on what Samantha said is depending on what state laws are, majority of states will have some kind of law that says, when that patient relationship starts and ends. Is it at discharge? Is it a month later, 6 months later, a year later, 2 years later? It really just depends on the state. What I can say as an investigator or someone with a lot of experience in this, even if someone legitimately has been discharged, you would be so surprised how many complaints we see when a relationship has started way after someone has been discharged and it goes bad. And then that patient somehow is like, hey, you know what? I can get that person in trouble by saying that it started before I was discharged, and I can file a complaint with the board and tell them that it started. And then how are you going to prove when it started? Right? That's going to be a really difficult thing for you. The other thing that we never mentioned in any of these scenarios is the top complainant that I get complaints from is the spouse or the significant other of the patient. So we didn't mention in any of these scenarios if there existed a spouse or a significant other, but and honestly, to the board, it doesn't really make a difference. That's not going to change whether there's a violation or not, but that's going to cause somebody out there to file a complaint. So this continuum of this, I really like the slide. It shows like this patient relationship starts, there's this boundary drift, boundary crossing, violation, and then someone files a complaint, not always the patient, right? Maybe the spouse who found the text messages, and then there's an investigation and potentially some discipline to the licensee. What I can also say in my experience is most of these kind of cases that I see started out not with, let's have sex in the clinic today. They've started out with a text message, an email, a conversation, something that started leading the two people to feel like there was some kind of more there than just a professional relationship. Next slide, please. We're kind of running out of time. So I want to do this scenario real quick, and then I'll try to be really quick. So a patient with hip pain is being seen by a highly skilled physical therapist in a private room. During the treatment session, the PT wants to do a technique on the patient and stands behind the patient and puts their body in contact with the patient's body to do the technique. The patient files a complaint that the therapist was intentionally being sexually inappropriate. Our question for you is, do you feel like there's inappropriate conduct in this scenario? I think the slide is the next slide. So yes, no, or I'm not sure. So I think this is really telling. We have, close between yes and I'm not sure, and some no's as well. And I think those are really kind of what we expected, because I see a lot of complaints like this because people aren't explaining what they're doing or asking permission, not because they're intentionally putting their body up against a patient's body and let me touch you for my own gratification, but they're just not explaining it. So the patient's perception, like I mentioned in the beginning, is this person is being inappropriate. Next slide, please. So since we're running out of time, I'm gonna go through these pretty quickly. It's your job to protect your patients, yourself, and the profession. Like we talked about in the beginning, don't expect patients to tell you they're uncomfortable. People just don't do that. Even we all in the slide said we didn't do that, right? When you're asking, like in the example before, say, is it okay if I touch you here? Is it okay if my body comes up against you? Should I put a pillow? Should I use a barrier? I'm really big on not using the phrase, I need to touch you here, or I need to do this, because if you say I need to do this, the patient automatically feels like, well, if I don't let them do it, I'm not going to get better because they said they need to. So ask, don't tell them. Communicate effectively and constantly gain consent. And try to remember, this big, 70% of the population has a trauma history. So to really treat every patient like they've had some kind of trauma, and something you do might trigger that. And sort of treat everybody like that. I just wanted to throw in this slide because this is always shocking when I tell this to students. So if you do decide to enter into some kind of an inappropriate relationship with a patient, or even just start texting or emailing, if you do get a complaint filed against you, boards can access all of this information: your cell phone records, your text messages, your emails, your personnel file, your social media. We can subpoena Facebook, Snapchat. We can subpoena I subpoena cell phone records all the time and text messages. We can go in and see who accessed this patient's medical record and when, and be able to even see the timestamp of when people's records have been accessed. So if you get a complaint filed against you and you've really have purposely done something inappropriate, or even initially thought, oh, I'm not sure, that this is bad or not, but then it gets, worse as you go, we can access all that information. And then I think it's also important for the next slide is to really think about, why are we here? Why are we all here? To prevent you all, obviously to protect the public and to prevent patient harm, but also to protect licensees, right? If you get a disciplinary action on your license, can't get a compact privilege for 2 years, you might not be able to bill insurance and being credentialed with insurance companies, be able to get another job, licensing, social. It's in a small town, the whole town finds out about it. That's an implication to you. Just the stress of having to go through an investigation with the board. And I want to add to that, sometimes there are complaints filed that are frivolous and you didn't do anything wrong, or a patient perceives it in one way, but you really didn't do anything wrong. You still, if you have to go through that investigation, is stressful and can cause, a great deal of anxiety and isolation for people. So you really want to just be as strict as you can with those boundaries, so you don't get yourself to a place where the perception of what you're doing is different than what it is. Next slide, please. I'm going to just turn this over to Mira to wrap us up.
Unmute myself. Sorry about that. So we've covered a lot of ground tonight, but don't worry, we have a ton of resources that are available to you. And one of the resources is this resource. So Jeff, you could go ahead and hit the next one. That really covers everything that we talked about tonight: the therapeutic relationship, informed consent. What is that power differential? Go ahead to the next slide, Jeff. We've given you a lot of suggestions, and you guys have given really good answers to the Slido questions. But again, red light, green light, and yellow light. So these are all suggestions for what to do and what not to do in an infographic, easy to read format. And then, of course, the last 2 pages of this infographic really talk about sort of the dangers. Go ahead and roll through, Jeff. Yeah. So we talked about how to deal with inappropriate sexual behaviors, comments, touching, things like that from patients. And so we have some suggestions about not freezing up and just ignoring it and hoping that that behavior goes away. And then last but not least, we have some tips about social media use. Many clinics will partition their social media accounts, their professional accounts from their personal accounts. And so that's something that you want to take care to protect when you're starting a new business or going out there and providing healthcare information in a professional manner. And then here's a QR code. Our committee has been busy all year trying to come up with different flyers, resources, presentations. So this QR code actually takes you directly to the FSBPT, our committee's resource page. In addition, FSBPT is pretty active on YouTube. So many of their previous webinars, the videos that you saw tonight, those can all be found on FSBPT. If you just put that into the YouTube search bar, all of those videos will pop up for you. And so we just sort of want to wrap it up. Jeff, you can go to the next slide. If you guys have any questions, you can put them here. I saw a couple comments in the chat feature as well. Or overtime by about 4 minutes. But if you do have anything that you want us to address, you can go ahead and put them in there. But when I say I speak for the whole committee, we really, really appreciate you joining us tonight. We hope that you gained at least 1 or 2 tidbits of really good information that will arm you for the rest of your school and into your clinical experiences and into your careers. Do you guys want to add anything?
No, I just wanted to thank everybody for being here. I really was. I'm shocked at the attendees. We have 282 attendees, and I was so happy to see at the beginning how many were actually students. I thought, oh, we're going to have, faculty or clinicians or who was going to be here. So, it's hard to get somebody to think that this is a topic that's important, but we all feel really passionate about how important this topic is. And, we want to protect the patients as much as we want to protect you and help everybody be, good, ethical clinicians who are, doing the best work they can do.
So you guys are awesome. Thanks so much for the comments. And then last slide, Jeff. If you guys have any questions afterwards, here's our contact information. And again, our group represents the Sexual Misconduct and Boundaries Committee, which is a committee of the FSBPT. And we've been working really hard to try to disseminate all this information for students, to the public, and to our fellow healthcare providers. So thank you so much for joining us, and we hope you guys have a great night.
Sherry, really quick, there was a question in the Slido before it kicked off. I don't know if you guys want to address it.
What was it, the one that said if you're the only PT in the rural setting? So that's a really good question. If you are the only provider in a rural setting, is it appropriate to treat someone you're having a relationship with? That is a really good question. So I think I'm going to go with that. It depends. Is there another close town over? Is it, because I would really, is it a long-term relationship? Is it something you just started a week or 2 ago? I would really be careful about having that relationship with a patient. I've had a couple of cases where then the insurance company questions, do they really need PT, or are you just seeing them because you want to spend time together? So there's a lot of factors. I think there is a big, it depends there to figure out what you need to do in that situation.
And there was another question. Oh, go ahead.
Oh. And so, Stephen, one of the questions I see on the Slido was use of videos and handouts. And actually, our committee is actually working on a student educational module that programs can use in both their PT and PTA programs to sort of fit your curriculum. It includes these cases, a slide deck, a pre-test, a post-test, sort of case studies, things like that. So I think between that module and accessing the videos on YouTube and the infographics and resource brochures from our committee FSBPT website, you should have all of the sort of resources that are available to you for sure.
And those resources are free on the website there for people to utilize.
So someone's asking, where can students and staff find laws regarding this? So it really is state dependent. And our committee did a whole project on this a year or 2 ago to look at the different laws per state. So depending on where you're practicing or where you're planning to practice, you would look at the statutes of the rules. Some states have a search bar where you can type in sexual misconduct, but usually you have to find it in like, who is a patient? The definition of what a patient is, someone who has been discharged from your care. It's not that easy to find rules specific to misconduct, although my state does have them. And it says misconduct is this: you cannot have a sexual relationship with someone who is a current patient. That's how it's defined in Oregon. But I know in other states, it's defined differently of when that patient-provider relationship ends. So it really is important state to state.
And just to be clear, that's in the Practice Act for that state is where you would find that information.
There's one more question there at the top.
Well, that's a tough one.
So I was going to let you take care of that.
Outside of this committee and this group, but if you're a student, I would definitely share that with somebody in your program, your CI, someone at the program. Maybe I'll defer to the professionals here who teach, of what you guys would do with that situation.
Yes, I would definitely hope that, I mean, that's a very difficult question for a student to handle. And I wouldn't necessarily brush it off, but maybe just have a conversation with them that, you know, and I don't know the whole context of that particular question, but you know, refocus on the task at hand, which is the physical therapy, and then definitely have a discussion with your clinical instructor, maybe even your DCE or your assistant DCE, to see, you know, how do you go about handling that particular question? You know, because I think that if you don't come back around to addressing that with the patient, they're going to feel even more hurt that you just ignored their question and never came back to answer it.
Thank you all. And we do have our contact information in the presentation too. If anybody wants to reach out, all of us are open and willing to answer any questions that someone might have.
Thank you so much for taking the time, everyone.
Yeah, thank you. Have a great evening.